Hello, everybody. My name is Peter MacPherson. I'm a public health physician, and I'm based at the Malawi Liverpool Welcome Programme in Blantyre, Malawi. Many thanks to my colleague, Dr. Dambe from the National TB Programme for setting the scene in Malawi. And I'm going to be reporting on a trial called the PROSPECT trial. We published the results of this trial a few months ago, but I'll go through the results in this presentation. And so just to set the scene a little bit more, so Blantyre is located in the south of Malawi. It's a major commercial center of Malawi and is home to about 1 million people or so. Over the last decade or so, we've established very high resolution surveillance systems for both HIV and tuberculosis. In urban Blantyre, about 1 in 10 adult men are HIV positive, and 16% of women are HIV positive. In 2019, we conducted a citywide prevalence survey for tuberculosis and found that 215 per 100,000 adults had pulmonary TB during that prevalence survey. This is a substantial reduction from what was found in the national TB prevalence survey conducted about 8 years previously. And that's matched by our trends in case notification. So a concentrating epidemic in Malawi, testament to the hard work from the national TB and HIV programs. And just to say very briefly, of course, that COVID had a major impact on TB in Malawi. This is work we published last year, showing that with the first wave of COVID in Malawi, we had an immediate 36% reduction in TB notifications across the city of Blantyre. And we estimate that approximately 333 people with TB were missed during that first wave. And so this speaks to the need to have better screening and better diagnosis for TB.
Your presentation is on presenter mode. Can you switch it to the top displays maybe?
Let me just try that. Better?
Yes, this is perfect. Thank you.
Apologies. Thank you, Mohammed. Good. So I'm going to set the scene. This is the study site for the PROSPECT trial, and Bangwe is a neighborhood in the northeast of Blantyre, very densely populated area where most of or a large number of the TB notifications from Blantyre come. And we established a TB research clinic based on a container clinic model with a min X-ray commander X-ray unit and with a CAD for TB version 5 box installed within the X-ray unit as well. And so background data, in a 1-year period before the trial, we surveyed nearly 12,000 adults coming through the door of the primary healthcare centre in Blantyre, and found that nearly half reported any TB symptom, and 10% of people coming through the door of the clinic had a chronic cough of more than 2 weeks. And this really speaks to the need to have a much more cost-efficient TB screening tool. If we were to offer gene expert testing to every adult with symptoms coming through the door, it would very quickly overwhelm the capacity of the clinic and very quickly bankrupt the Malawi health system. And of course, the diagnostic cascade is very leaky in Blantyre, as it is in many settings as well. And essentially from this cohort study, you see that virtually nobody receives same-day diagnosis and treatment of tuberculosis in primary care. So we designed the PROSPECT trial to really address the limitation and to see whether we could achieve same-day diagnosis and treatment of TB and HIV within a primary care setting. So we recruited 1,462 adults with symptoms of TB attending Bangwe Health Clinic, and they were randomized into one of 3 arms. In the standard of care arm, participants were asked to wait in the acute waiting area where they were assessed by medical staff. There were no physicians available in the clinic, but clinical officers and nurses, and on site was gene expert testing, HIV testing and HIV and TB treatment if requested by health workers. In the second arm, participants were offered an oral HIV testing intervention and linkage to HIV treatment for people with newly diagnosed HIV. The hypothesis here was that if we were to link people into HIV treatment earlier, we might prompt a more thorough investigation for TB or even unmask TB as part of a HIV workup for treatment. In the third arm, participants received the HIV testing intervention and additionally received a digital chest X-ray. If the CAD for TB version 5 score was above a threshold of 45, we then requested an on-site sputum gene expert test. And we followed up all participants across all 3 arms for 8 weeks, where we saw them at the clinic again and assessed for outcomes in terms of TB treatment initiation, missed TB diagnosis by taking a sputum sample and X-ray at 8 weeks, and also looked at mortality and costs as well. So the primary trial outcome was the time to TB treatment initiation. And here I've listed the secondary trial outcomes as well. And of course, because we had 3 arms, these were pairwise comparisons between arms. This table shows the characteristics of the trial participants with the standard of care in this column, the HIV screening intervention in this arm, and the HIV and TB screening intervention in this arm. And the main takeaway from this table is that characteristics were well balanced across trial arms. Very important to note as well that about 1 in 5 adults across the 3 arms were HIV positive, but that treatment of antiretroviral therapy was extremely high at over 95% in all 3 arms. And again, this is what we see in urban Blantyre through our surveillance, where the HIV program has done a tremendous job at achieving high coverage of HIV treatment. So this Kaplan-Meier plot summarizes the primary trial outcome. And in the blue curve, we can see the TB treatment initiation amongst the HIV TB screening arm, the purple for the HIV screening arm alone, and the pink arm is the standard of care arm. And the main takeaway from this graph is that the HIV and TB screening intervention substantially increased the yield of TB diagnosis and the timeliness of TB diagnosis. So to formally summarize those results, in the first 2 columns here, you can see the TB treatment initiations by day 56 comparing the 3 trial arms. So in the standard of care arm, 5 participants were initiated on TB treatment compared to 8 in the HIV screening arm and 15 in the HIV and TB screening arm. And the time to TB treatment was significantly and substantially shorter in the HIV and TB screening arm, with a median of 1 day in that arm compared to 11 days in the standard of care arm, giving a hazard ratio of 2.9 with a significant 95% confidence interval. No participants in the standard of care arm achieved same-day initiation of TB treatment under routine conditions, whereas 40% in the HIV and TB screening intervention arm did. Again, a significant difference there. But of course, not all participants achieved same-day initiation as we would have hoped. We did sputum culture and gene expert on all participants at day 56 to look for undiagnosed or missed TB. And these data were similar between arms, with only 1 missed case in the HIV and TB screening arm and a non-significant relative risk here, but numbers are very small for this secondary outcome comparison. And there was no difference in mortality between the 3 trial arms. Interestingly, despite the very high coverage of antiretroviral therapy, the HIV testing intervention had a substantial and significant 90% reduction in undiagnosed HIV infection by day 56. So this table summarizes the trial cost effectiveness analysis outcomes. And so the way to read this table is the interventions are across the rows here. And so in the first column, you can see the mean cost per participant for the interventions in each arm. So in the standard of care arm, it costs the health system approximately $21 to deliver all interventions, whereas in the HIV and TB screening arm, it was $41. So an incremental cost of nearly $20 to provide the HIV and TB screening intervention. The main driver of that additional cost was actually gene expert testing cartridges. In this column, we can see the quality adjusted life years gained by the intervention, and we can see that there was an increase in quality adjusted life years in the HIV and TB screening arm and the HIV screening arm. But again, important to note that the follow-up period was relatively short here. The HIV testing, or just to say so, Malawi does not have formal cost effectiveness thresholds. So we have evaluated the probability of cost effectiveness at 3 different cutoffs, so $400 per QALY up to $1,200 per QALY. And the HIV testing intervention had a high probability of being cost effective at these thresholds, whereas the HIV and TB screening intervention had essentially 0 probability of being cost effective at those interventions. Now, just to say, of course, the follow-up period is very short here, and we would expect the benefits of the HIV-TB screening intervention to accrue over a much longer period. So right now we're doing mathematical transmission and economic modeling to look at the longer term impact of these interventions at the population level. I just wanted, before I finish, to highlight a couple of other randomized trials ongoing. We believe that the Prospect trial is the first randomized trial to evaluate a CAD solution for screening for TB, and perhaps even the first randomized trial of artificial intelligence in medicine. We are aware from searches of databases that there's 3 other trials ongoing. In South Africa, Kirtan Dida's group are undertaking a community-based case-finding trial using CAD that's due to start soon. Here in Malawi, my PhD student, Dr. Rachel Burke, is conducting a randomized trial amongst HIV-positive adults admitted to hospital with a combined intervention of CAD plus Fujilam compared to usual care. That trial has completed follow-up and will be reporting soon. And also in Malawi, Professor Liz Corbett has been conducting the SCALE trial, a large community-based active case-finding trial using CAD. That trial, unfortunately, had to be terminated due to COVID, but also the lower than expected prevalence of TB found in the community. We will report the results of that trial in the near future too. So in conclusion, computer-aided chest X-ray screening plus universal HIV testing significantly increased the timeliness and yield of TB diagnosis and substantially reduced undiagnosed HIV. We think that routine TB screening using CAD and HIV screening at primary care level has potential to contribute to elimination goals. We did find that the prevalence of untreated HIV and TB were both below anticipated, and that is consistent with the successful scale-up of the national programs in Malawi. We found that the cost effectiveness analysis demonstrated that the universal HIV testing intervention was cost effective even where ART coverage was extremely high. But also we think that the costs of digital chest X-ray plus CAD and expert will need to be substantially reduced. We're doing a lot of work now modeling how we can optimize thresholds to reduce the number of expert cartridges used, which are the main drivers of costs here. So I'd just like to say, of course, that this evidence contributed to the recent WHO consolidated guidelines on tuberculosis. CAD is now recommended for the first time as an alternative to human interpretation of digital chest X-ray amongst adults. And to finish by thanking the Wellcome Trust for funding this study, and of course the huge number of people here in Blantyre and internationally who contributed to the study. And thank you for your attention.